Good afternoon, everyone. At the outset, my sincere thanks to my friend Sanjay for giving me this opportunity to be here in this very wonderful meeting. And I bring greetings to all of you from PGI Chandigarh and also from INAZL, the Indian National Association for Study of Liver. So the question I have been asked to answer is that in fatty liver disease or in NAFLD, which patient need further evaluation and treatment. So I thought over this, and finally, I came to the conclusion that all patients with fatty liver disease actually would need further evaluation, and everybody would need treatment. Why I'm saying this is based on some data, and I'll just show you and quickly take you, through this presentation. The first thing we need to understand is that all fatty liver disease are not same. And unless you evaluate them and unless you stratify them, it will not be possible for you to, say, which patient stands whether it is just NAFL or what we call simple steatosis, or whether it is, gone into NASH with fibrosis, cirrhosis, and, all the full spectrum. So the evaluation obviously has to be done in everybody. And once you have evaluated, and depending upon the severity of the liver disease, you would then decide whether that's the patient who's the candidate only for lifestyle interventions, or do you need to give him some, NASH-specific pharmacotherapy as well. So this, as I said, this will all depend on the evaluation and the stratification. So the question is then, what kind of stratification, how do you evaluate them, and what kind of treatment is again to be given to them. So again, in general, we see fatty liver so commonly, and I'll show you maybe one slide on the Indian data as well. But whenever a patient with fatty liver comes to you, he may come to you just because of incidental detection on ultrasound, and which basically he got it done maybe for dyspeptic symptoms or maybe for elevated liver enzymes or something like that. So if that is the scenario, you cannot presume that fatty liver disease is nothing but NAFLD. There are certain other causes of fatty liver also which obviously needs exclusion before you call somebody as NAFLD, because NAFLD still today is a diagnosis of exclusion. So which actually means that obviously you need to take the history of alcohol, which is obviously, as I said, by definition, it's a non-alcoholic fatty liver disease. In our part of the country, hepatitis C, Geno 3 is very common, so we always exclude, hepatitis C. Look at the profile of the patient, especially young fatty livers. I think Wilsonian would also need exclusion. More important than that is, the history of steatogenic drugs is very, very important. There are various drugs, which cause fat in the liver, and, some of them are, corticosteroids, methotrexate, amiodarone, tamoxifen. I think all this needs to be asked, as I said before. These all become, secondary causes of fatty liver, and by definition, NAFLD we call it, which is so closely associated with, metabolic risk factors or metabolic syndrome. So as I said, this is the spectrum. You can have just fat in the liver, which we now call it as NAFL, or some of these can progress on to NASH with fibrosis, cirrhosis, and it's all the complications. But the other thing which also needs to be, kept in mind is that fatty liver disease is maybe one manifestation of all these metabolic risk factors. So patient has come to you in totality. It's not only the fatty liver which you have to see, because in the early part of the fatty liver disease, when the liver disease is not very severe and there is not much of fibrosis, most of these patients, would die of, either cardiovascular disease or malignancy. It's only when the liver disease, progresses into, severe fibrosis or cirrhosis or advanced fibrosis that they start having complications and mortality because of liver disease. So a holistic approach is very, very important. And because of the metabolic syndrome, they could have chronic kidney disease, they can have cardiovascular disease, they can have bone disease, they can have some malignancy. So I think the evaluation has to be done in totality, not only looking at the fatty liver. I think that would be another message which I would like to give. I think again, before I go into the evaluation, I think most of you are aware about the kind of prevalence of fatty liver disease you have in this country, and I'm pretty sure it is not less here. In Chandigarh, at least we see every second or third person has non-alcoholic fatty liver disease. Let's not talk about the alcohol here. So it's the non-alcoholic, and this is the systematic review and the meta-analysis which is published very recently from All India Institute of 50 studies with 25,000 patients, and look at the prevalence in adults is around 38.6, close to 40%, and even in children it's around 35%. So very high prevalence. But what I'm saying is that all fatty liver disease are not same. These all prevalence studies may just looked at the fatty liver. But in this particular study, which is our consortium study, we have a consortium in India called Indian Consortium on NAFLD or ICON-D, where 42 centers across the country, we participate, and contribute to this. And this is our interim analysis, which was published last year around 4,000 patients with fatty liver disease. And look at this, if you do the non-invasive assessment, around 20% of them already, have significant fibrosis. And when you look at the fibroscans in them, 30% of them had a value which was more than 8 kilopascal, suggesting significant fibrosis, and 10% of them were already cirrhotics. And they did not know it. They came to the liver clinics of different centers only as fatty liver. It's only on evaluation you find that these patients have advanced fibrosis or cirrhosis. So that's what I'm saying. This evaluation is very, very important, because the ultrasound will only show you fatty liver. It may not show you, especially this kind of fibrosis, which would be picked up on, FibroScan and various other non-invasive modalities. So I'll start with a case, and typically which you must be seeing in a clinical practice, and then I think that will help you in understanding about the evaluation and the management of these patients. So this is a 51 years gentleman with diabetes, hypertension, average body weight of 90 to 95 kg in last 10 years, and the ultrasound was done for dyspepsia, and it showed hepatomegaly with steatosis. And examination again showed that he had obesity. Again, I think you should use the Indian cutoffs for overweight and obesity, with 23 as normal, 23 to 25 as overweight, and more than 25 as obesity. Similarly, for central obesity, the 90 centimeter is the cutoff for males, and 80 centimeter for females. I think these are the cutoffs which you should be using in your clinical practice. So he was hypertensive, but on examination he was normotensive that time. So again he was worked up. Look at his platelets, even though normal, 150 to 450,000, we will take it as normal, but they are on the lower side. They should immediately start coming. So platelets are very, very important part, which tells you about the ongoing hepatic fibrosis. Then is the enzymes are not much elevated, very minimally elevated, just 50 and 48. But look at this, the AST is slightly more than ALT. That's another thing which should immediately come to your mind, that are we dealing with only just plain and simple fatty liver, or it is just beyond that, and he could be having fibrosis in the liver. His other synthetic functions, albumin was fine, and his triglycerides were elevated, HDL was low, but then he was worked up. As I said, we will always do viral markers in them, exclude hepatitis B, hepatitis C. If the enzymes are elevated, and depending upon the clinical profile, we also do autoimmune and the celiac workup, and then depending upon the age, young patient, we can also need to exclude Wilsonian, as I said, and in slightly older patients, more than 55, we also do an iron profile. All this are, as I said, secondary causes need to be excluded. So finally this was done on him, but then are you getting a sense of it? Because he had fatty liver, his platelets are slightly on the lower side, his AST, ALT are slightly elevated, and AST is more than ALT. So this is what we are getting, and his triglycerides are elevated. So now what further, and what should you be thinking about the severity of fatty liver in this particular patient? So as I said, these things are very, very important. Age is a very important, determinant of severity of fatty liver disease. A young boy of 20-25 years with fatty liver disease is likely to get, more of simple steatosis or NAFL. But on the other hand, a 60-65 years old, postmenopausal female is likely to get, maybe significant fibrosis or even cirrhosis. So that's very, very important. As I said, age is a very important. Postmenopausal status is very, very important. As I said, AST to ALT, ratio is very, very important. Alone platelet count is very, very important. And I'll come down to these scores, APRI and FIB4 and other scores and FibroScan. But more important is the number of components of metabolic syndrome. As the components of metabolic syndrome increase, your chances of having severe liver disease go up. Now you look at this gentleman was obese, diabetic, hypertensive, dyslipidemic, so almost full house. Everything, all the 5 components of metabolic syndrome were there, so which actually puts him at a risk of having a severe liver disease. So all these things, need to be seen in a patient. Again, there are lots of non-invasive tests, NITs we call it, which have come very recently, in last 4 or 5 years, and various societies, international societies have given, various kinds of these scores. Unfortunately, many of these scores are what we call patented or the proprietary items from some of the companies. They are not freely available, but commercially, even if they are available, they are costly. So I think we very recently, last month have come out with, our own Indian guidelines, so-called the INASL guidelines on fatty liver disease. This is published only last month in JCH, which is our official journal. So there we have given a very simple algorithm about the evaluation, which is more patient friendly and which is more suitable for Indian settings. So what we are saying is that if you are found to have fatty liver incidentally because of dyspepsia like this patient, or we are even suggesting that high risk patients like metabolic syndrome, diabetes, obesity can even be screened for fatty liver, and once you have that, you must rule out first obviously the secondary causes, and once you have done that, look at those clinical risk factors which I told you, age, gender, and the metabolic syndrome components, and then AST. But then we are suggesting that you just calculate 2 simple scores on your mobile. One score is called APRI and other is called FIB4. What is the APRI? APRI is AST to platelet ratio index. How to calculate that? I'll just show you. And other is FIB4, which is fibrosis 4 score. So AST to platelet ratio index has only 2 components. One is AST, other is platelet. Whereas FIB4 has 4 components, AST, ALT, age and platelet. So 4 components. So how do you do that? And based on that, then you decide whether you want to refer this patient for a next step. And the next step we are saying is the elastography or the FibroScan. So this is this is available on your mobile, on your iPad, on your computer, very easy. Put in the AST of the patient, say 50 in this patient, the normal value of say 40 of your lab, divided by platelets in thousands. Here it is 150,000. So divided by 150, multiplied by 100, and the value is auto calculated as 0.8. So as I said, any value more than if it is more than 0.45, you cannot exclude significant fibrosis. This patient can have significant fibrosis. The accuracy of these tests is close to around 70%. Similarly, FIB4, you put in the AST, ALT, age and the platelets, and the value comes as 2.45. These are all, as I said, can be done on your mobile. Again, a value more than 1, you cannot exclude significant fibrosis. If it was less than 1 or if the APRI was less than 0.45, you were pretty sure that this patient does not have significant fibrosis, or for that matter, any kind of fibrosis, and then you can manage that patient at your own level with only lifestyle interventions, no referral, no FibroScan, nothing is required. But with values like this, as I said, the next step we are saying is that you must do a FibroScan. And on FibroScan, as I said, we divide them into 2. Suppose you get a value which is less than 8 or 8.2, again you are kind of excluding significant fibrosis. Again, these patients will require only lifestyle interventions. If it is more than 13 or 13.6, he is likely or can have cirrhosis. I think they need to be managed separately. We are not discussing NASH cirrhosis today. And if the value is between 8.2 to 13.6, in addition to lifestyle interventions, you can decide to give him, some kind of NASH pharmacotherapy, which will do that. So in this patient, when we did the FibroScan, the LSM was 9.1 and CAP is a controlled attenuation parameter which tells you about fat in the liver, which was 310. This is liver stiffness measurement. This tells you about hepatic fibrosis. So more than 8.2 means that he definitely had significant fibrosis. So once you have done that, the next is, as I said, how do you treat him? So if it was not significant fibrosis, less than say 8, and the APRI-5 for normal, you can only give him these lifestyle interventions. So lifestyle interventions is what? Basically control of all the metabolic risk factors. Overweight, obesity, you need to tell them about the weight reduction, exercise, calorie reduction. The time probably will not permit me to get into the details, and these recommendations and the guidelines are freely available in our journal, as I said, the nasal guidelines. And once you have done this thing, there's always a question: if somebody is not able to lose weight on lifestyle interventions, is it possible, or can you advise him bariatric surgery, or for that matter bariatric endoscopy? The big answer would be no, because till today we don't have any RCTs, good data to suggest these modalities at treatment for fatty liver disease. If they are otherwise indicated, presence of fatty liver disease is not a contraindication unless somebody has already gone into cirrhosis. Then comes the role of pharmacotherapy. I told you where to use drugs. So drugs to be used only if somebody has significant fibrosis. So lifestyle interventions plus drugs if you have significant fibrosis. And more important is if lifestyle interventions are easy to say, but then when it really comes on to doing the lifestyle interventions, if you tell the patients to do say 10% of the body weight, maybe around 10-15% of them are able to do it, and 5%, maybe around 25 to 30% will do it. Many of them will regain weight, what we call weight recidivism. So I think there are always issues with lifestyle interventions, so you always have to take the help of these drugs. So as I told you, if your patient is falling into this category, in addition to lifestyle interventions, you can give them NASH-specific pharmacotherapy. Now comes the last question: which pharmacotherapy and how to choose between the drugs. So most of the societies, this is my last but one slide. So most of the societies would recommend vitamin E and pioglitazone. In addition, in India, because the saroglitazar is available only in India, we are also recommending saroglitazar, and all these can be done in addition to lifestyle interventions in patients with F1 to F3 fibrosis in situations where you either have a biopsy proven NASH with or without significant fibrosis, or even on non-invasive assessment. If you think that this patient is likely to have significant fibrosis, you can take a decision about this thing. Now how to choose between these three drugs, maybe if the time permits we can have that discussion during the discussion. As I said, the holistic approach is very, very important. And before that, I think all the metabolic risk factors you should know. If you don't know, maybe you can take the help of an endocrinologist. The good control of diabetes, hypertension, dyslipidemia is very, very important, and statins are not a contraindication, even in patients those who have elevated liver enzymes. And as I said, cardiac evaluation, kidney evaluation, a holistic approach has to be given in evaluating other systems. So let me summarize, ladies and gentlemen, what I said, that all fatty liver disease are not same, and we must do the risk stratification and assess the severity of liver disease, and then decide whether you can manage these patients at your own level, or you would like to wish them to a center where a fibroscan, liver biopsy and other modalities are available. And once it comes to the management, lifestyle interventions with control of metabolic risk factors is very, very important. Pharmacotherapy to be given only in patients those who have either histological NASH, or if on non-invasive testing, if you find that somebody has significant fibrosis, but mind it, this is all without cirrhosis. Now how to choose the drug? As I said, you have three drugs, and maybe we can have in the question that how to choose between these three drugs if you decide to give somebody a particular drug. A holistic approach is very, very important. In addition to liver, I think the assessment of extrahepatic organs is very, very important in this. I'll also take this opportunity to invite all of you to our annual conference of INASL, which is happening 3rd to 6th August in